The following podcast is part of a certified educational activity titled Teaming Up to Reduce the Burden of Cancer-Associated VTE, applying the latest guidelines and evidence in gastrointestinal and hematologic malignancies and other cancer settings. Access the entire activity and complete the post-test at peerview.com/MWJ860. Downloadable slides and practice aids are also available.
Welcome to this educational activity, Teaming Up to Reduce the Burden of Cancer-Associated VTE, applying the latest guidelines and evidence in gastrointestinal and hematologic malignancies and other cancer settings. I'm Dr. Alok Khurana from the Cleveland Clinic, Lerner College of Medicine, and I would like to discuss today brand new data regarding risk prediction, primary prophylaxis, and treatment of cancer-associated thrombosis, as well as brand new guidelines that have been updated with these new data and basically transformed the field of cancer-associated thrombosis with the introduction of a new class of agents. Cancer patients with venous thromboembolism carry a significant burden that affects not just their own care, but the public health burden of cancer worldwide. Cancer patients who have VTE have a threefold increase in all-cause hospitalizations, a threefold increase in days that they're in the hospital once they're admitted, and they incur much higher inpatient costs, outpatient costs, as well as total healthcare costs. In fact, according to a couple studies, cancer-associated thrombosis, which includes both venous and arterial thrombosis, accounts for 9% of all deaths in cancer patients with a good performance status receiving outpatient systemic therapy, and is in fact a second leading cause of death in cancer patients, cancer, of course, being the first leading cause of death. The occurrence of venous thromboembolism in cancer patients is associated with increased mortality during chemotherapy. And in one study that we did a few years ago, looking at causes of death in patients with cancer, we found that the chance of dying from VTE is 47 times higher in the cancer population than in the non-cancer population. Thus, cancer-associated VTE is highly consequential for patients with cancer and contributes to the public health burden of cancer and its complications worldwide. A common refrain around cancer-associated VTE is that not all cancer patients are affected equally. A general rule of thumb is that about 1 in 5 cancer patients will develop a blood clot at some point during the natural history of their illness. The flip side of that, of course, is that 4 in 5 cancer patients will never develop a blood clot during the natural history of their illness. So it does become important to understand what are some of the risk factors that predict for cancer patients getting VTE. How can we identify cancer patients at high risk for VTE and therefore potentially either prevent it from happening or at least educate patients about the warning signs and symptoms of VTE so that they can be made more aware of this possible complication of their systemic therapy. Over the past few decades, there's been a lot of research into risk factors for cancer-associated VTE. These can be categorized, as on this slide, into about 4 different risk categories. Number 1, and probably the most important, is cancer-related risk factors. These include the type of cancer. This is probably the best known risk factors. Everybody who's taken care of cancer patients knows that, for instance, pancreatic cancer patients are at much higher risk of a DVT or a PE than, say, a breast cancer patient. Or a primary brain tumor patient is at a much higher risk of a DVT or a PE than a sarcoma patient. In addition to the type of cancer, the histology is also important. Adenocarcinoma patients, for instance, have greater risk than squamous cell cancers. The grade of cancer, the poorer the grade or the more aggressive the tumor biology, the greater the risk. And timing is also important. The initial period after diagnosis, the first 3 months to 6 months, is when the majority of VTE events occur in patients with cancer. In addition to cancer-related factors, the second risk category is treatment-related factors. These are things we do to cancer patients: admitting them to the hospital, conducting major surgery, giving cancer patients systemic therapy, putting central venous catheters in. Even supportive care therapies such as erythropoiesis-stimulating agents or blood transfusions are also associated with a high risk of treatment-related VTE. Patient-related risk factors are also important, although not as important as in non-cancer settings. Probably the most important patient-related risk factors are age. Older patients are more likely to get VTE. Race and ethnicity. In the United States, for instance, there have been good studies that have shown a higher rate in patients who are African American compared to patients who are Asian American, and a high risk of comorbidities. The more the comorbidities, including kidney function, kidney dysfunction or renal dysfunction, pulmonary dysfunction, cardiac issues, all of those slightly add to the risk of VTE. And then finally, there's an emerging category of biomarkers that have been used to predict the risk of DVT or PE in cancer patients. We'll get into that a little bit. There's none sort of one biomarker that's used widely or can be used widely in this setting, but some common biomarkers include some really simple ones, such as the complete blood count, a low hemoglobin, a high platelet count, a high leukocyte count are all predictive of the risk of DVT or PE, as well as some more complex assays such as tissue factor by ELISA or activity, D-dimer, P-selectin, and thrombin generation potential have all been investigated. Let's get a little bit into the prediction of cancer-associated VTE, not simply to understand the epidemiology of VTE in this population, but also as a way to understand which patients are most at risk so we can intervene and prevent and potentially reduce the risk of VTE in this population. As I discussed just a few minutes earlier, the risk factors for cancer-associated VTE are many. About a decade ago, my colleagues and I put together a large analysis of a prospective cohort study trying to identify which are the most important risk factors and trying to score them in a risk assessment tool so we could identify high-risk patients. This score, now about 10 years old, is known as the Khurana Score, and identifies 5 different variables that we considered most important in identifying the risk of VTE. These include a high platelet count, a low hemoglobin, a high leukocyte count of 11,000 or higher, a high BMI of 35 kilogram per meter square or higher, and most importantly, the type of cancer. So if you had stomach cancer, as shown on the right, or pancreatic cancer, you get 2 points. For some of these other cancers, like lung or lymphoma, you get 1 point. GYN cancers, bladder and testicular, also you get 1 point. Other cancers, such as say breast cancer or colorectal cancers, you get 0 points. But if you have any of these other risk factors, so you could be a breast cancer patient, but if you had a low hemoglobin and a high BMI and a high platelet count, that would put you at a high risk. High risk in our original study was defined as a score of 3 or higher. Although that's been changed over the years, and we'll get to that in a few minutes. When we first came out with this risk score 10 years ago, this was the only validated risk assessment tool. And at this point, it's been validated in over 40,000 patients worldwide. As this slide shows, there's been a bunch of newer scores that have attempted to modify or alter the original risk score in a way to sort of get better prediction, both positive predictive value and a better negative predictive value. The most validated of the newer scores is the one by Peppinger and colleagues shown at the bottom, which takes away some of the other biomarkers that we had included and the BMI and adds a D-dimer. All of these risk scores that are listed here are not quite ready for prime time yet and have not been tested in trials of prophylaxis. So I discussed them to say that there's a bunch of ongoing research in this area, but according to the guidelines, the original score is still sort of the only validated score to be used for prediction of cancer-associated VTE in this setting. Another important point to note, and this also becomes important when we try and understand when do we use risk assessment and what do we use risk assessment for, is that to note that the risk of VTE varies over the course of illness. The highest risk is during the first few months after cancer diagnosis. This may be a biological reason for this. There may be reasons when cancer is untreated that it's creating more of a hypercoagulable state, and as a treatment is instituted, the state dissipates over a period of several months. But it may also be that many of the interventions that we use, such as surgery, such as hospitalization, such as systemic therapy, also all occur in the first few months after cancer diagnosis. And so that could add to this sort of increased burden of VTE in the first few months after illness. So the clinical take-homes from this introductory section, number one, it's important to recognize that cancer-associated thrombosis, today I'll be talking mostly about venous thromboembolism, but also arterial events such as stroke and MI are a major burden to cancer patients. They lead to increased hospitalization, increased urgent care visits, delay of treatment, morbidity, and mortality. and that there's now a way to identify patients who are at high risk for DVT or PE using a simple 5-variable validated risk tool that can predict both patients at high risk for VTE as well as patients at low risk for VTE. Let's try and understand how we can use risk assessment to understand the data regarding primary prevention and thromboprophylaxis. And in this next section, I'll discuss 2 trials that just came out in the past year or so that have led to a change in all the major guidelines covering this subject. The 2 trials, Avert and Cassini, will be reviewed over the next section. Both trials were published in actually the same issue of the New England Journal of Medicine in February of 2019. And both trials are very similar except for 1 or 2 key differences, which I'll point out. Both trials studied outpatient thromboprophylaxis, so whether outpatient DVT or PE can be prevented in cancer patients initiating a new round of systemic therapy. Patients could be treatment naive, or they could be starting a new chemotherapy regimen. The primary endpoint for Avert was the first episode of VTE over a 6-month period of thromboprophylaxis. And as you can see from the table on the left, the prophylactic agent used in this setting was apixaban. And there was a high risk reduction, both in terms of absolute risk reduction of DVT or PE, as well as relative risk reduction. In the placebo arm, patients with a Khurana score of 2 or higher had a risk of VTE of about 10%, which is what would have been predicted from the initial observational studies of the risk score. And using apixaban, that risk could be reduced to about 4%. And that p-value was highly statistically significant. Most people would consider PEs to be a very key component of preventing DVT or PE. And the PE rate came down from 5.8% in the placebo arm to 1.7% in the apixaban arm. And that's an almost 2/3 reduction in PE alone. And you can see the same graphic display of this on the right. Safety is always important, especially when you're using blood thinners in a preventative setting. This is a low-dose use of a direct oral anticoagulant, apixaban. And thankfully, there was not any major signal regarding bleeding. Major bleed rates were 3.5% in the apixaban arm compared to 1.8% in the placebo arm. But this analysis actually included events that occurred after apixaban was stopped. If you focus on the time period that patients were on apixaban, then the increased risk of major bleeding is about 1%. This did not lead to an increased mortality. And clinically relevant non-major bleeding was about 7.3% with apixaban compared to 5.5% with placebo. Overall, the number needed to harm, which is how many patients need to take apixaban to have one major bleed, is about 101. So that's generally considered safe in a prophylactic setting like this. The second trial published at the same time was Cassini, also targeting the same population, cancer outpatients, mostly solid tumor patients and lymphoma patients, initiating a new systemic therapy regimen. Could be chemotherapy naive, or they could be starting a 2nd-line or 3rd-line treatment regimen. Most patients were naive. Patients had to have advanced or metastatic cancer. Patients had to have a Khurana score of 2 or higher. That's how they were deemed to be high risk. And they were also treated in this trial with rivaroxaban, so different direct oral anticoagulant at the dose of 10 milligram once a day. Couple key differences between Cassini and Avert. The major difference was that Cassini introduced a baseline ultrasound. So after patients were enrolled on the trial, they underwent an ultrasound of the lower extremities. And about 5% of patients were found to have a clot before they even received 1 dose of the anticoagulant. And so those patients were included in the trial, but not included in the randomized portion of the trial. A second key difference was that patients also underwent screening ultrasounds every 8 weeks while they were on the trial. There was a high rate of drug discontinuation or switching leaving the trial because of transition to hospice or progression of cancer or a bunch of different reasons. And about 38% of events occurred in patients who had discontinued either the apixaban or the placebo. And so the absolute risk difference in this trial was not as dramatic as you saw in the Avert trial, 8.8% down to about 6%. So that's a hazard ratio of 0.66. If you focus on a pre-specified intervention period, which is what happened while patients were actually getting the drug, then you get a hazard ratio closer to what we see in Avert, 6.4% down to 2.6%. That's a hazard ratio of 0.4. And the number needed to treat is about 25 or so. With avert, the number needed to treat to prevent one event is about 17 or so. Again, safety was established in this trial. Major bleeding rates were roughly similar to what we saw in the apixaban avert trial. 1% increased risk of major bleeding with rivaroxaban in this setting, about a 0.5% increase of non-major bleeding with rivaroxaban compared to placebo. P-values were not significant, but the number needed to harm is very similar to what you see in avert, which is about 100. There was no increase in mortality, so even if even if there were adverse events, they did not lead to increase in mortality. In fact, in Cassini, we found that in a pre-specified analysis of the combination of the primary endpoint plus all-cause mortality, that was lower with rivaroxaban, 23% compared to 29% with placebo. That hazard ratio is 0.75, and the p-value was significant. How have clinical guidelines reacted to these two new findings? Over the past several months, including as recently as last month, all major guidelines that tackle this subject of prevention and treatment of cancer-associated VTE have included these two clinical trials, and they have viewed both Cassini and avert as both being complementary and confirmatory of the finding that outpatient cancer-associated VTE can in fact be reduced with low-dose direct oral anticoagulants, either apixaban or rivaroxaban. The ASCO update recommends primary prophylaxis in high-risk cancer patients, again defined as a Khurana score of 2 or higher, with either apixaban or rivaroxaban, or based on an extrapolation of older low molecular weight heparin data, or using low molecular weight heparin. Prior guideline had already recommended that patients with myeloma on thalidomide or lenalidomide-based regimens receive thromboprophylaxis, and that recommendation continues in this ASCO update. NCCN also recently updated their guidelines and also are now recommending a primary prophylaxis, again in patients with a score of 2 or higher, also with apixaban or rivaroxaban, also in patients with myeloma on IMiDs with either aspirin or apixaban or low molecular weight heparin or warfarin. ITAC, which is an international group of guidelines, is recommending prophylaxis in locally advanced or metastatic pancreatic cancer patients treated with systemic cancer therapy, so separating out the pancreatic cancer population, largely because that's a group that's perceived to have very high rates of DVT or PE. This actually aligns with the risk score because patients with pancreatic cancer automatically get a score of 2, so it's actually not any different than the other two guidelines, as well as patients with a score of 2 or higher based on either cancer type or other combinations, again recommending the same two agents, apixaban or rivaroxaban. And then finally, ISTH, which is a major thrombosis organization, has also recommends primary thromboprophylaxis in patients with a score of 2 or higher with DOACs, either apixaban or rivaroxaban. What about other reasons to prophylax patients? Currently, cancer patients who are admitted to the hospital are also perceived to be at high risk of DVT or PE. Large randomized trials have not been undertaken in the cancer population specifically. That's a knowledge gap. But there have been trials of cancer patients that were included in medically ill patients admitted to the hospital. And so based on those data, current recommendations, ASCO, NCC, and ITAC, are all that if you're a cancer patient, you're admitted to the hospital for any acute medical illness such as pneumonia or infection, febrile neutropenia, then you should be considered for inpatient thromboprophylaxis as well. Major surgery is another indication for prophylaxis. This is a long-standing recommendation. It's been around almost for 2 decades at this point. And all three, ASCO, NCC, and ITAC, recommend inpatient thromboprophylaxis. And they do recommend continuing post-operative prophylaxis in high-risk patients. These are abdominal or pelvic cancer surgery patients, specifically recommending that low molecular weight heparin be extended past the hospitalization period into the post-discharge period for a period of up to 4 weeks. So what are the take-homes from the data regarding primary prevention and thromboprophylaxis? The data from 2 large randomized clinical trials, both published in the same issue of the New England in 2019, has led to an update of all major guidelines, which now recommend offering thromboprophylaxis to high-risk patients with cancer defined as a score of 2 or higher, initiating a new systemic therapy regimen. Inpatient prophylaxis had been recommended previously, and that continues to be a recommendation. Post-surgical prophylaxis was recommended previously, that continues to be a recommendation. And finally, it's important that we execute these guideline recommendations by implementation science efforts, where we use health system approaches such as electronic medical record charts or consult services set up to discuss prophylaxis for cancer patients in this setting. Here's the latest evidence for treatment of acute cancer-associated VTE. These guidelines and these recommendations have also changed in the past couple of years because of the advent of a whole new class of anticoagulant drugs. I just briefly discussed anticoagulant drugs for the use of thromboprophylaxis, but the same class of drugs, DOACs, can also be used for treatment and are increasingly being recommended for treatment in specific situations associated with cancer. The data supporting the use of direct oral anticoagulants comes from a set of randomized clinical trials that were conducted over the past few years. Many of them have been published in high impact journals, including NEJM and JCO. And over the next few slides, I want to briefly review the results of these trials and then review the guidelines that utilize these data to support using direct oral anticoagulants along with low molecular weight heparin depending on the individualization of treatment in cancer. One of the largest randomized trials supporting the use of direct oral agents in this setting was the Hokusai VT trial that was published in the New England. This used a drug called edoxaban in the setting of a cancer patient with a new diagnosis of an acute symptomatic DVT or PE. Patients with this new diagnosis were randomized to receive either starting with low molecular heparin for a couple of days and then switching over to edoxaban, or the older standard, which is low molecular heparin continuously for 6 months. In this trial, they used dalteparin as the standard arm or the control arm, because dalteparin is currently the only low molecular weight heparin that has an FDA approval specifically for the treatment of cancer-associated DVT or PE. So they used the FDA-approved package insert, which is dalteparin for 200 units per day for the first month, and then dropping after that to 150 units per day for the next 5 months. And the primary endpoint was, are DOACs as good at reducing the risk of recurrent DVT or PE as low molecular weight heparin is, and do they increase the risk of bleeding or do they preserve that? So it was designed as a non-inferiority trial between low molecular heparin versus edoxaban. This table shows the primary endpoint, which was the combination of recurrent VTE or major bleeding. So they didn't separate out recurrent VTE and major bleeding, which is what most trials with anticoagulants do. But they said, well, if either one happens to a cancer patient, that's a bad outcome. So let's just measure what's the percentage of bad outcomes in patients on one arm versus the other. And overall, recurrent VTE rates were lower by about 4%, close to 4% on the edoxaban arm. So 34 events in the edoxaban arm compared to 54 in the dalteparin arm. This was a very large study, about 520 patients in each arm. And major bleeding, on the other hand, was slightly higher, 33 patients in the edoxaban arm compared to 17 in the dalteparin arm. So that's up by about 3%. But combined, it met its definition of non-inferiority. And so this certainly has become one possible option that DOACs can be used safely in this population, but with concerns for an increased risk of major bleeding. I personally did not anticipate that we would see a reduction in recurrent VTE. I would have been happy with just a similar rates of recurrent VTE. So it's an advantage that there were lower recurrent VTE events, but there was certainly caution exercised about the use of or the increased risk of major bleeding in this population. So there was an investigation into which patients were more likely to bleed. That's shown on this slide, where basically you can see that the risk of major bleeding was greater in patients with GI cancers. If you took out patients with GI cancers and you looked at other cancers such as lung cancers, there's actually no increased risk of bleeding at all. And this was published in a subsequent subgroup analysis. A second randomized trial was SELECT-D, which was published in the JCO, looking at 12-month outcomes of placebo versus rivaroxaban in the second, after 6 months. But the more key to sort of our discussion today is the initial period of treatment. So for the first 6 months, patients were randomized to rivaroxaban versus dalteparin, same control arm as the Hokusai trial. And then there was a second randomization to see how long patients needed to be on anticoagulation. The second randomization didn't accrue enough patients, so it's sort of meaningless to discuss that. But the important issue was that VTE recurrence rates were reduced, both in the initial period with rivaroxaban as well as after the second randomization at the 6-month time frame, suggesting again, not only that rivaroxaban is associated with the reduced risk of VTE when patients are taking dalteparin, but in the post 6-month period, also suggesting that VTE recurrence rates can be suppressed if you remain on rivaroxaban beyond 6 months. A third set of trials was using apixaban. We have 2 randomized trials in this setting, a smaller one called ADAM VTE, which compared apixaban 10 milligram twice a day for the first 7 days, and then 5 milligram twice a day for 6 months to dalteparin. The primary endpoint of this trial was major bleeding, and secondary endpoints included VTE recurrence and a major plus clinically relevant non-major bleeding. Very few major bleeding events were observed in this trial with apixaban, in fact, none. And so because the power wasn't enough, because there were so few events, it didn't quite meet its primary endpoint, but established some safety and efficacy. The primary outcome of ADAM VTE was looking at major bleeding. As you can see from this graph, it looked great for apixaban because there were basically no major bleeding events at all in the apixaban arm. And that's shown in this table here, zero events with major bleeding in the apixaban arm out of 145 patients, 2 patients in the dalteparin arm, so 1.4%. But because the event rates were so low, the study was not powered enough to identify significant differences, and the p-value was 0.14. VT recurrence rates were also lower with apixaban, 1 patient out of 145 in the apixaban arm, and 9 out of 142 in the dalteparin arm, so 0.7% versus 6.3%. Certainly, this required confirmation in a larger randomized trial. And this trial was followed up very recently by Caravaggio, which is an outpatient trial of randomized to apixaban or dalteparin, but with a much larger sample size, 1,100 patients. And that's what we'll look at next. The results of ADAM VTE were dwarfed by the very recent publication of Caravaggio, which is a very large trial of apixaban for the treatment of cancer-associated VTE in 1,100 patients. This again took the same approach as the Hokusai VTE trial, taking cancer patients with the proximal DVT or PE randomized to either apixaban or dalteparin. Unlike edoxaban, which has a low molecular weight heparin lead-in for a couple of days before you transition to edoxaban, apixaban can be started at the initial diagnosis, so there's no lead-in on the study arm. And then the control arm was dalteparin given just as it was in the Hokusai study. Unlike Hokusai, Caravaggio separated out the outcomes. So there was an efficacy outcome, which was recurrent VTE, and a safety outcome, which was major bleeding. In terms of recurrent VTE, results are very similar to what we saw with the rivaroxaban and in the other apixaban trial and in the edoxaban trial, which is now a theme across all of these direct oral anticoagulant trials, that there are fewer recurrent VTE events with apixaban in the study. And thankfully, there was not a real increase in major bleeding that had been a concern with some of the other randomized trials, but we did not really observe that in the Caravaggio trial as shown here. So if you look at clinical outcomes with Caravaggio, recurrent VTE rates were about 7.9% with dalteparin, down to 5.6% with apixaban. This met the p-value for non-inferiority, not quite significant for superiority. And then major bleeding was about 4% with dalteparin and 3.8% with apixaban, which was clearly not significant. So overall, very reassuring regarding both safety and efficacy in this population. How have guidelines responded to these new data? ASCO was updated before the Caravaggio results came out. So ASCO is recommending initial treatment with low molecular heparin followed by edoxaban or rivaroxaban on its own. NCCN updated with the Caravaggio data, so is recommending all of these DOACs, apixaban, edoxaban, rivaroxaban. But because of the concern for gastric or gastroesophageal cancer bleeding noted in the SELECTI trial, as well as somewhat noted in the Hokusai trial, NCCN recommends low molecular weight heparin in that specific setting. And then it recommends other DOACs if above regimens are not appropriate or available, but that's obviously very, very few patients would fall into that category. And ITAC also recommends initial treatment with low molecular heparin, DOACs or fondaparinux, again, including DOACs in the first-line setting of the treatment of cancer-associated VTE. So what are some clinical takeaways from the treatment aspect of cancer-associated VTE? I think the biggest takeaway is that DOACs are now an important new option for both the initial and the long-term treatment of acute VTE. This is a big change in this field because for almost 15 years, we have been saying that low molecular weight heparin monotherapy for 6 months is the most most standard approach to treating cancer-associated VTE, and that recommendation has now finally been taken over by the inclusion of DOACs in the first-line setting. It is important to understand patient selection. As I mentioned, even though Caravaggio had no increased risk of major bleeding, the other two trials did have some increased risk of major bleeding, specifically in patients with GI cancers. And so we have to be very careful that we are making sure that we are selecting patients that are not at risk for bleeding. I personally stay away from direct oral agents in patients who have a luminal gastric cancer, so an esophageal cancer or G junction mass that could be at risk for bleeding. But beyond that, we found that at my institution, we found that using direct oral agents is quite safe and is more efficacious. Overall, this is a win-win for cancer patients. More than 95% of patients will not have a recurrent VTE, and more than 95% of patients will not have major bleeding with oral agents, which sort of avoid the concern for daily self-injection that you see with the low molecular weight heparins. So I definitely consider this a win-win for our cancer patient population. Overall, we've studied the prediction of cancer-associated VTE, a risk model to identify patients who are at high risk, looked at some emerging and guidelines and new data regarding primary prevention of cancer-associated VTE, which is sort of hot off the presses, as well as brand new data for the treatment of cancer-associated VTE, which now evolves direct oral agents into the front line of the setting. Lots of exciting things are happening in the field of cancer-associated VTE. All of these things are beneficial for our patients, and it's great to be able to update you with these results. Thank you for your attention.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/MWJ860. Supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.